So, morning, everybody. Welcome to this meeting of the Board of Directors of Lincolnshire Partnership NHS Foundation Trust. My name is Kevin Nokia. I'm the chair. I would say first of all that we would normally start our board meetings with a patient story, and we had one scheduled for this morning, but very sadly the patient concerned is unwell and can't join us. So we've decided not to fill that slot on the agenda with something at short notice, because that would have been unfair to everybody concerned. So we're going to go straight into the routine business. Peter, do we have any apologies for absence?
Sorry, no, Kevin, we don't have any apologies for absence for the first part of today's meeting.
Thank you, I'm grateful. Declarations of interest are as outlined in the paper. Has anybody got any declarations they wish to make that are either additional to those on the paper or for the purposes of today's meeting? No. Okay, so let's move on then to the minutes of the meeting that was held on Thursday, the 29th of July. Has anybody got any points of accuracy or other comments that they might wish to make on those minutes? Ananta?
Yes, just a minor thing on page 9 when it talks about the learning disabilities review. It is LEDER, the spelling of leader. The acronym that's used nationally is LEDER. Thank you.
Thank you, Ananta. We can make that that correction. Are there any other points on the minutes of the last meeting? If not, are colleagues content for me to sign them as an accurate record? No one's saying no, so I will assume then that I may. Yes, thank you very much. Let's move on then to item 1.4, which is the schedule of actions, all of which are marked either closed or complete, apart from the continued work on risk 179 on the risk register, where work is currently in hand. Has anybody got any questions or comments either on the closed or complete actions or the one outstanding action which sits with Chris at the moment? Okay, if not, let's move on. The next item is some remarks from the chair. Now, I don't intend to use this item on the agenda routinely for a kind of long speech or anything. My comments this time are it's good to I've managed over the last few weeks to start to get out and see services, which is good. I've enjoyed that. I've been really impressed by everything that I've seen in terms of, you know, staff and management clearly living the values of the trust, really keen to talk about what they do and to talk about the impact that they have. It's been, you know, all of that has been really impressive. There's still lots for me to see and lots for me to learn, and I'm really conscious that I'm still on that, you know, on that learning curve. You know, in terms of developments in and around the trust, we've got we know that there is a lot going on around the development of the integrated care system, and we are carving out some time in January for a dedicated board development session to give us some time to consider all of the issues around system development and what LPFT's role in that is. I think that's going to be time well spent and something that we absolutely need to do. But beyond that, and I should of course note the fact that one of the most pleasurable things I've been able to do over the last few weeks is confirm the appointment of Sarah as Trust CEO, and I couldn't let this opportunity pass to record the board's formal congratulations to Sarah for her appointment as substantive CEO. So well done, Sarah. And I'm really looking forward to continuing to work with you as a real person rather than a pretend CEO. So really looking forward to that. Let's move on then to item 1.6, to the minutes of the Council of Governors meetings on the 5th of August and the 6th of September. They're there for comment, question, observation. So if anybody has any comments, questions or observations on those, then please shout. If not, then let's move on. And I think the next item is 2.1, and that's Anita, that's yours.
Thank you. Good morning, everybody. I'm Anita Lewin. I'm the Director of Nursing, AHPs and Quality here at LPFT. So this paper that I'm presenting is a feedback on the board stories over the previous year, so from September 2020 to May 2021. This was a new report that was written for the first time last year. It became very clear when I was writing this one that it was very different from the previous years, and I the board stories have always been a key part of what we kind of cherish, I think, to start our boards off on the right footing, to demonstrate our values at the start of any board meeting. But I think with COVID, with the changes in the way we've operated the last 12 months, what's happened over the last 12 months is we've seen staff that are coming to present on behalf of service users their stories, but also given staff the opportunity to talk about some of the fantastic work that they've done. I don't intend to go through the summary of each of the board stories. The vast majority of us were there for most of them. I'm happy to kind of take the paper as read, but I did want us to have a discussion and a consideration for us as a board, because we've heard lots of good things this year, and that's been really important. And I think it's been extra important to us in the difficult times of the last 12 months. But I think it's also important that as a board we hear some of the challenging stories and some of the times when we haven't got it so well for people, and where there's areas for improvement. So what I want us to do, and potentially it's something we can either do today or take away and have a thought and discussion on the future of the board stories and how we hear some of those challenging stories, because I do think that's incredibly important, as well as the good stuff. I think what's been clear is the staff have really enjoyed the opportunity to share some of their good work. So I think it's about us getting a balance. So just in summary, I think this paper clearly demonstrates the importance to the board of hearing these stories to start our meetings, and I think that's incredibly important. There is no doubt there's been a different feel to them the last 12 months, but there's been a different feel to most things the last 12 months, let's be completely honest. But I think we do need to kind of consider the purpose of the board story, what it brings to our meetings, and how we kind of plan those out going forward for the next 12 months. Thank you.
Thanks, Anita. I think probably the right way to approach this is to have that bit of thinking time separately, from the board, and it's something that we could perhaps pick up at a board development session. For me, I think three things. I think we need to fall into the trap of only hearing the good news. We need to avoid that trap. It's a really easy trap, to fall into. We need to hear about things that have gone wrong, just as much as we need to hear about things that have gone well. And I think too that one of the, and I've only been exposed to a couple of stories so far, but what strikes me is even the things that have gone well are tough. None of this is easy, and whether the outcome's a good outcome or an indifferent outcome, we learn a lot from the challenges of getting there. So they're my kind of immediate observations, but definitely we should find some time to think about how we want to use board stories in the future. Now I've got a couple of questions. I think Sharon.
Thank you, Chair. Sharon Robson, I'm Chair of the Quality Committee. I'm a non-executive. I do support the idea of taking this into a board development session. And one of the questions which I feel I should know the answer to, but I don't, is whether we have an actual tool for using patient stories, which describes the kind of governance arrangements around the use of patient stories. And apologies, Anita, if we have, but I thought that would be an area that we could look at in terms of development in the use of why we're using the patient stories in the first place, because if the purpose is to enable the board to reflect on services and look at what improvements we need to make, I feel that the loop should be back into some of those visits that we do as executives and non-executives in terms of learning, and I don't feel we've quite completed that learning. Thank you.
No, I agree, Sharon, and we have, starting on Monday, a new patient experience lead in the organisation, and I do intend to work closely with them and about that whole feedback loop. In previous kind of board stories, and certainly prior to this year, the executive team have kind of left the board stories with quite a few actions and recommendations and things to feed back on. There hasn't been so much of that this year. But I think you're right, we can do that formal loop and then exactly that, feed it back through the NED visits and through some of the work of the patient experience lead.
Thank you.
Kevin, you're on mute.
Thank you, Peter. It was bound to happen at least once, and I might as well get it over with early in the meeting. Di, I think you've got a comment.
Thanks, Kevin. Di Bailey, one of the non-exec directors. I agree with the suggestion that we incorporate this in terms of a board development session. And I also think, Anita, what you've just said about the patient experience lead, that would be a good way to progress this. I think we need to acknowledge that this has been an unprecedented year for our staff. And so I think actually them having the opportunity to come here has been a valuable one. When I looked at just the summary of the patient stories in the paper, I could see that there were some themes coming out of that, themes around complex needs, themes that spoke to our values, themes around the relationship between the need when we intervene to look at mental health and physical health holistically. So I wonder whether, given that this is obviously a summary of those very rich stories, there's an opportunity there for maybe some more thematic analysis that perhaps the patient experience lead could help us with in terms of lessons learned from these, because I think there's a real rich opportunity for that we should make absolute use of. That may give us some material that we could perhaps take into some of those conversations with the people who use our services and sense check with them in terms of, these are the sorts of things that we're finding, and use that as an opportunity to engage in further dialogue about some of those more difficult experiences, perhaps, because I think sometimes if you start with some information that you give people, it helps them to talk about their experience a bit more, rather than them trying to come to that conversation almost from a standing start, really. So I think there are some ways in which we could use this information to better effect, and I think that would help us and also fit with the values of the organisation.
Brilliant. Thank you, Di. Thank you for your comments.
Thank you, Di. Ananta.
Thank you, Kevin. Hi, I'm Ananta Dave, Medical Director here at LPFT. And I think a board development session would be good, because while we are talking of patient stories, the message we are sending out in the trust is we need to look after all our people and listen to all our people, whether the patients, carers, staff, and of course, looking after staff well helps us to provide better patient care. So I don't know whether there is mileage in us discussing at a development session how we include staff stories from all levels, right from admin staff to senior staff, clinical staff, staff with various challenges. and see how we can incorporate them into board stories so the remit of them grows. I mean, we're calling them patient stories at the moment, but would welcome that conversation if possible at the board development session. Thank you.
Thank you, Ananta. So, Anita, thank you very much for the paper. It's been a really helpful little discussion. I think two things that come out of that: we'd like to have some time at a board development session to look at scope and future use of board story, and whether or not that includes staff and patients and other service users, how we get the kind of richness across that. And then I think Di's really important point that we could do some analysis around all of this, and not use them, and I think we can discuss how we do this at board development, but make sure that we don't have these as one-off standalone events at each board, and that we use that opportunity to draw some insight out of it, which I think would be really useful.
Yeah.
Anita, thank you very much. I think the floor is still yours, isn't it, for the next item, which is the infection prevention and control annual report.
Yes, thank you. I am going to take this as read, and I am going to say that this has been looked at detail in the Infection Prevention and Control Committee and in the Quality Committee. I really do just want to say, and I know the word unprecedented is used an awful lot at the moment, but for everybody all over the world, it's been an unprecedented year. But for us in mental health, you know, the way we've stood up and responded to the IPC challenges have been incredible. Here in LPFT, you know, I am incredibly proud, and I talk about the infection prevention control team, which actually up until a month ago was a single individual who, with fantastic response from our operational services, have really kept LPFT safe for the last 12 months. Our management of COVID has been something that I'm incredibly proud of. As I say, I don't intend to go through this report in detail. It has been looked at in detail, but I think just for the board, I'm hoping this provides assurance of the activities and mitigations we've taken over the last 12 months to keep both our staff and our patients safe, and also the plan going forward. We have seen increased investment in the infection prevention control function of the organisation as a necessary response going forward. But other than that, I'm just happy to take comments. Just one thing I was going to say was just we have now got an infection prevention control committee that was stepped down and incorporated into a patient safety committee some time ago, but that has been stood back up as a standalone committee that now feeds into quality committee that I chair. But other than that, I'm happy to take any questions, any comments.
Thanks, Nita. As you say, unprecedented is a word that gets bandied around a lot, but rightly so in this case. So questions and comments, Philip.
Yes, thank you, Chair. Philip Jackson, non-executive director. I just wanted to echo the comments that Anita's made about, you know, a fantastic job that we've done in this area during very difficult times indeed, and it's a very positive report. So congratulations to everybody in that respect. I just had a question, Anita, on Appendix 2, just with regard to the link practitioner network, which we said has been delayed, obviously because of COVID. I just wondered whether or not, you know, with hindsight and with the experience we've had over the last year or 18 months, whether we still think this is definitely a requirement, and if it is, you know, are we in a position where we'll be able to establish it fairly quickly?
It met last Friday, Philip, but it was too late for the report. We did get it back up and running again from last Friday, and I do think we also now have the operational services have made more investment in matron roles, and they're very much linked in with the infection prevention control nurse. So that whole link is It was more the meetings and them bringing people together, because we just needed people at the front face in terms of kind of managing the last 12 months. But that work is back up and running, and it is very much back off the back boiler. Yes.
Okay, thank you for that assurance. That's great. Thank you.
Thank you.
Thank you, Philip. Tim.
Hi, Tim Harry, Non-Exec Director. Thanks, Anita. Yeah, just to echo other people's comments, I mean, that was a tremendous response. I just got a question, which is really getting a sense, looking ahead. Obviously, the measures put in for COVID had an impact on other healthcare acquired infections. And I'm assuming that you've done the analysis in terms of what we should continue as additional measures in light of that. But I just wanted to get a sort of sense how much of that there was, because obviously there's practicalities around some things that you probably wouldn't want to continue because they impinge and constrain on other factors. Thank you.
It is a conversation we're having regularly at the moment, Tim, and to be fair, it is very difficult for us in the NHS at the moment, because our rules and regulations around us in the NHS are so very different to what people can now do in their personal and private lives away from work, and keeping some of those alive and well. And I'm hearing of other organisations that are beginning to have norovirus outbreaks and other outbreaks. And I'm touching every piece of wood around me to say that that isn't currently the position in Lincolnshire Partnership Foundation Trust. We know we made some very tough decisions in the beginning with our dormitory-based accommodation around removing some of the beds to ensure 2 metre social distancing. We're keeping that in place at the moment. Chris Higgins, Director of Operations, I'm sure we'll be having several conversations as the pressure on those starts to increase. But actually, I do have to say, as the Director of Nursing of this organisation, I have requested and asked for some very difficult decisions to be made, and have been fully supported with those, which I'm thankful to colleagues on, because that they haven't always been easy things that I'm asking for. But I've never felt that, to be honest, that I was going to battle. It's never felt like that. It's been a very supportive environment that I've worked in, which hasn't been the case, I believe, in some other areas. So the honest answer to that question, Tim, is that we're looking at it what feels like daily and sometimes hourly. We're watching what comes through, but actually the safety of our staff and patients will absolutely remain at the heart of every decision that I take and make. So it is a case of watching this space.
Yeah, thank you, Anita. I know it's complex, so appreciate that.
Thanks, Tim. And Di.
Thanks for the report, Anita. I took assurance from that. I thought it was a good report. Can I just ask, it's in relation to catheter care and the information that was in the plan, and there was reference there to an increased use of catheters, and also a comment about there being a move away from traditionally affected groups in terms of catheters being used. And I just really wanted a little bit more information, if you can, or point me to where I can get it, in terms of which groups are we seeing that perhaps we weren't seeing before, and are we sure that staff have got the required training and necessary support if we're dealing with a different population to one than we've been seeing previously?
Absolutely. So I will kind of connect you up with Sarah Alexander, who's my head of physical healthcare, will give you further detail. But I think into two parts for that. In terms of have staff got the skills, it is something now that we're incorporating into some of our training, but not for all staff. We do have a team of physical healthcare nurses now that work with our inpatient facilities, so they will often take the lead in the catheter care. And I think some of the discussions that we've had in the physical healthcare steering group is around the younger age group, to be fair, and some of the presentations in terms of some of the incredibly physically unwell that we're getting, whereas historically back in the day when I kind of was doing some of this, you know, it's very much our older adults wards and really only on our older adults wards. So yes, but I will put you in touch with Sarah Alexander offline as well, Di, but it is an important factor that we do consider. Thank you.
Thank you.
Thanks, Di. We don't have any more questions from colleagues, Anita, so a couple from me, if I may. The first is just to note the fact you said something about the decisions that you're taking. It's worth noting, isn't it, that all of our decision making around this is going to be subject to fairly intense external scrutiny, you know, through the inquiry into COVID, for example. So, you know, the fact that we're able to evidence, you know, robust decision making is really important, and your report speaks to the robustness of that. So, you know, really appreciate that. Echo what people, what colleagues have said about, you know, it's an impressive report. Really high level of assurance to the board around IP&C, and thank you, Anita. Thank you to you and your colleagues.
Thank you.
Okay, so let's move on. The next two items, Jane, are yours, 2.3 and 2.4, about service changes. So over to you.
Thank you, Chair. Good morning, everyone. Jane Marshall, Director of Strategy, People and Partnerships at Lincolnshire Partnership. Thank you for that introduction, Chair. This is an important paper for us for decision today. And I want to start by just explaining briefly what this service change is. It is, over the last 2 years, our people who run these services have taken the unfortunate opportunity of us having to temporarily close one of our inpatient units for children and young people's mental health and converted that into what we're calling an intensive home treatment or extended home treatment service, which is a community-based service and is about the people who worked in the inpatient unit plus some other staff working into people's homes to support children and young people's mental health. And that is in line with our vision of enabling people to live well in their communities. I want to commend the people who've made this change and converted a difficulty into a positive, and also acknowledge the support of Carl Macy, Chairman of the Lincolnshire Health Scrutiny Committee, for holding us, both our commissioners, NHS England, and us as a provider, to account for this service change and giving us the space to make the case whilst giving constructive challenge. The Lincolnshire Health Scrutiny Committee is an important partner in supporting us with scrutinising these types of changes because they are significant changes. So this paper summarises and asks the board for a final decision and approval on that, making that service change permanent, which is about the permanent closure of Ash Villa unit in Sleaford as a children and young people's mental health inpatient service, and the permanent adoption of the new model of care, which is about a community facing service. Thank you, Chair.
Thank you, Jane. Tim, you have a comment.
Hi, yeah, thanks, Jane. Obviously, just to highlight that this went through the People Committee where it was thoroughly discussed, and we supported the recommendation to make this a permanent change. The other comment I was going to make was that we felt that this was a really good example of really good stakeholder management, and highly commended on that basis.
Thank you, Tim. Sharon.
Yes, hello, thank you. Thank you, Jane. I'm very much for the model of a community facing. I just wanted to just grasp that issue of when we do actually need to admit a young person, are we confident as an organisation that across the region we have capacity to keep children as locally as we can?
Thank you, Sharon, for that question. It is an important point and has been the challenge that we've had from the Lincolnshire Health Scrutiny Committee has always been about ensuring children and young people who are Lincolnshire residents stay close to home and in Lincolnshire, and if they do need a bed, there is a bed available for them. So this service change, it's important to note, relates to general adolescent unit patients. There are always has been a number of more complex children and young people who, because of their needs, have had to go out of area for their care. And an example of that is an eating disordered patient who would need an inpatient stay. So in terms of our assurance to the board that there will always be sufficient capacity for children and young people, yes, we have planned as part of this that at any one point in time there'll be up to 2 general adolescent unit patients out of area, but our experience is that that's been very exceptional, and most of the time we've managed to hold those people in Lincolnshire with that intensive home treatment and support. But we monitor it very, very closely because that is in the context of a national and regional challenge in terms of inpatient child adolescent mental health service units, where we have seen a number of closures of beds temporarily sometimes in the region. So we monitor it really, really closely and will continue to do so. But our teams are absolutely dedicated and focused to making sure we do everything we can to help a child stay close to home, and in the exceptional need for an out of area bed for general adolescent patients, we obviously work hard to make that available and link with our partners accordingly. I don't know if my colleague Chris Higgins, the Director of Operations, wants to comment at that point.
Chris.
Yes, thank you. Yeah, Chris Higgins, Director of Operations. Just kind of really backing up what some of the comments have been said there, is that this is a real good news story for Lincolnshire and for the children and the families, is that we're helping a number of children to stay at home with their mums and dads and their kind of care networks that were previously unable to do that. And it is a good news story in that respect. And certainly picking up on the point that Sharon Robson raised there in terms of access to beds. We don't have delays. People are able to access a bed when they need that. We're not getting any delays that we used to. And certainly before the model, regularly children would be stuck in inappropriate care settings, just waiting for a bed to become available. Because we've reduced the demand for beds, because we're supporting so many people at home, that problem has gone away. We just don't get that same issue, which is, it's very, very rare. So yes, it's certainly heading in the right direction for us, and it's delivering what we intended for our service users and the families. And obviously, because of the success of that, other organisations around the country are looking to the model that we've been able to implement here in Lincolnshire to be able to replicate that, because we know that other areas have got pressures with a number of children going to hospital and might not need to be there. So certainly we're sharing our best practice with other organisations as well.
Thanks, Chris. That's really helpful. Sarah.
Thank you, Chair. Sarah Connery, Chief Executive at the Trust. Just to build on what Jane and Chris have said, really, in terms of our ultimate vision to support people to live well in their communities, this is what this is all about. But I think there is something there in the challenge on, we see sort of 61 general adolescent unit beds as I don't know whether to use the word target, but I think there's something for us maybe as an exec team to talk about how we will escalate what a tipping point might be over and above that 61, because it will go up and it will go down, and we're talking about single numbers, as Jane has said. So I think there's something for there in terms of board reporting on this in the future, in terms of the IPR of what that out of area position might look like. Thank you. Thanks,
Sarah. Philip.
Yes, thank you, Chair, and Philip Jackson, Non-Executive Director. Thanks, Jane, for the report. I mean, we do know, of course, that this left shift in services generally is something that we want to be trying to achieve across a whole range of activities in the Trust, and we know that it's better for both service users and their families. And I think the report you've put together, Jane, particularly demonstrates that, with the practical experience we've got of this. And it's good that we've also had robust challenge from the Lincolnshire Health Scrutiny Panel, and they've also come out in support of what we're doing. And it's also good to hear what Chris has said about other trusts up and down the country looking at what we're doing and seeing this as sort of groundbreaking work which they can hopefully learn from as well. So as a non-executive director, I'm sort of very assured with the report that we've got and the challenge we've had from the Health Scrutiny Panel, and I think it's right for the board to support the proposals that you're putting forward this morning.
Thank you, Philip. And Ananta.
Yeah, thank you, Chair. Ananta Dave here, Medical Director at LPFT. I would like to commend everyone involved in this very good piece of work, which has really had very sensitive and consistent and adequate time lengthwise stakeholder engagement before concluding this piece of work. And I think it's the right thing to do. The vast majority of our young people need general adolescent unit beds, which we are able to manage most of them in the community, which is very good for them. I think we just need to be mindful, as Jane has said earlier, about the impact of the national pressures and how we capture that within our local Lincolnshire communities, because there is national pressure on specialist adolescent beds, be it for eating disorders or very complex physical and mental health conditions combined. And I think that's where we need to be mindful of how pressures outside Lincolnshire might impact on what we are able to offer within Lincolnshire. And going forward, that would be something that we monitor closely. Thank you.
Thanks, Ananta. So let me draw some conclusions out of that, Jane. The first is, in terms of, as Philip described, the left shift in care, what's being proposed, is absolutely right and consistent with that direction of travel and to be welcomed. I think that it should be noted that all of our stakeholders have welcomed both the change and the process that we've gone through and the way that we've engaged stakeholders in the process, and without naming names, there are other organisations in the system that might be able to learn something from, the way in the sensitive and kind of inclusive way that we've handled this. I certainly got some feedback from, one of our MPs the other week that was very positive about the way in which we'd managed all of this. It's also worth making the point too that the feedback that we've had from families and service users is generally positive, and they've welcomed the new approach. And but like any kind of service change, we're going to have to monitor the impact, aren't we? And that's built into the process. This is not a do it and walk away process, so that kind of goes without saying. So with those comments, I need to put it to the board because this is for the board to decide. So are colleagues happy to endorse the proposals in Jane's paper? Yep, so I think the answer to that is yes. Thank you very much, Jane. Before we move on to the next paper, I've got to say something about, we've got some technical problems, which means that it's currently not possible for people without NHS accounts to see the broadcast. So for the purposes of record, the recording still will be available. So I just need to make the point that we're carrying on with the recording. It'll be available after the event. So apologies if you've been trying to join us live. So with that mild technical announcement, none of which I actually understand, but it's what I've been told to say, I'll hand back to you, Jane, for the next item.
Thank you, Chair. Jane Marshall, Director of Strategy, People and Partnerships. This paper is another service change, this time for our older adults who are accessing mental health services available from Lincolnshire Partnership, and again is for decision by the Board of Directors today. This paper, in common with the previous one, has been through a robust process in terms of working this time with our clinical commissioning group colleagues in Lincolnshire as they commission this service on this service change, which in a nutshell is about us making sure that where possible there are intensive home treatment support available for older adults and their carers in their own homes, but sufficient bed-based capacity in Lincolnshire in specialist units for us to admit older people if they require that. And links to an opportunity we had to trial a home treatment team for people with functional mental illnesses, anxiety and depression, for example, when we refurbished one of our wards in Lincoln, Brant Ward, Witham Court. So again, I want to commend my colleagues across the organisation who've led this change, particularly the leaders from the older adults division and the staff who've taken on board again a change of model and made it work. Last Friday I was speaking to a member of the home treatment team and she was so energised and so passionate about this service change. It's also allowed us to create a centre of excellence at Witham Court, Lincoln, for our older adults inpatient services, and have seen some quite incredible results. So, for example, a 91% reduction in the number of older adult patients who don't, a 91% reduction in admissions, sorry, to fluff my lines on that one, and no out of area patients. So again, here for decision by the board, having been rehearsed by the People Committee as well, and for approval today to make this service change a permanent one. Thank you.
Thanks, Jane. I know all about fluffing lines, so don't worry about it. Any questions or comments for Jane on this second service change? Sarah.
Thank you. Sarah Connery, Chief Executive here at the Trust. I just wanted to formally acknowledge Jane's leadership in this in terms of presenting to Health Scrutiny Committee and other bodies. So I just want to formally say thank you in terms of, I know you've sort of taken the divisions with you along the way for support, but it's these are really thorny issues in terms of actually closing inpatient beds, but I believe we've got the right outcome today, and it's a much more comprehensive and responsive service. So thank you very much for that.
Thanks, Sarah. Chris, you're next.
Yeah, just wanted to make the point. I mean, it's made in the paper really, but you know, for our older people, this is a great service that we've been able to introduce here in Lincolnshire. And you know, we know that often when people get admitted in that older age group, when they get into an inpatient bed, that change in environment and layout and the detachment from families can have a really negative impact at times on people's well-being. And so what we're able to do with this service is to help people, exactly what we're trying to do with an organisation, which is help people to stay well in their communities. And it's definitely the right thing to do, and we've seen that from the patient feedback and the staff feedback and carers that are involved in those patients' care. So absolutely right thing to do, and just really thankful for Jane to help us steer us through that.
Thanks, Chris. For my part, I just echo what Sarah said. Jane, well done for steering this through. It is another really positive service change, and one again that has been expertly navigated through stakeholders and supported by them. So congratulations on that. As you said at the outset, closing any inpatient facility is hard work and fraught with controversy. So the fact that we've got here with a minimum of kind of blood spill has been is credit to you. So thank you for that. So again, we're asked to approve the service change proposed in the paper. Our colleagues happy to do that. So I think the answer to that is yes. So Jane, thank you very much. Anita, I think it's back to you for item 2.5.
It is. Thank you very much. So this item is the Combined Domestic Homicide and Serious Case Review, known as JBR 2016. I'm conscious that I have a lot of new colleagues that are now part of this, so may not know the details of this case. However, it was a very public and in the media case. But this was published formally last week, but I think it's important because of some of the joint recommendations for us all that is brought through board today. I don't intend to share the detail of the case, but just in terms of headlines, and these are obviously not the names of the true names of the individuals, but in April 16, Sarah and Sarah's boyfriend Daniel, who were both age 14 at the time, were arrested for the murder of Sarah's mum and sister at their home in Spalding. They were convicted of the murders in November 16, and at the time were identified as the UK's youngest double murderers. So there was a great deal of media interest in this at the time. Both Sarah and Daniel had quite a lot of short interactions with various services in the previous 4 or 5 years, and I'm certain colleagues will have read the detail of the report, and it is out in the public domain for reading. What I will say in the findings of the report, the report strongly makes the point on more than one occasion that it couldn't possibly have been predicted that Daniel and Sarah would go on to do the horrific act that they did. However, it does highlight some broader learning for us all. One of the key bits that was picked up at the time, it wasn't a key part of this, but for us particularly in LPFT, there was a lost referral into the SPA, and I do know the detail of this actually because I was managing the SPA at the time, and there was a lost referral into the SPA. It wouldn't have impacted on this case, but that led to us doing a very detailed overhaul of the single point of access at the time. As I've highlighted here, we took some immediate actions in there. I have in this paper kind of identified the parts that were particularly picked out for LPFT. There was family therapy that at the time we didn't provide. And we now employ a number of family therapists in our children and young people service. I do also have to say that Donna Bradford, our head of carers, also provides Meriden training, which is a family therapy based training that numerous amounts of our staff have gone through. I have within the front sheet of this paper 2016 and the services offered by kind of our CAMS and our kind of children's services are in a very different place as we sit here in 2021. So I've taken the opportunity in this front sheet to identify some of the new services that have been developed since that time. The Healthy Minds Lincolnshire service, the mental health support teams into schools, the Future for Me services. Now, whilst we can't say in absolute clarity that either Sarah or Daniel would have been referred into those services, there is a strong possibility looking at the offer of those services. So really, in summary, it is to take through the board this report that was published last week. The findings, the recommendations will be managed through the Safer Partnership, the Children's Partnership Board that I am a member of. And really the Board of Directors, and I think it's important that we acknowledge that the tragedy of this incident, it really is, you know, I came into it and have been part of this since I came into post. It really is a tragic incident. I think it's important that we receive and note the findings of the report and, you know, pledge to be part of the recommendations, and also to note the additional services that are now in place following this incident in 2016. Thank you.
Thank you, Anita. I have a question from Sharon.
No, thank you, Anita. It's a very difficult read and a very well written report. I've just got one question for us as an organisation, and it's around the broader learning. And this is something that's come out from other incidents, you know, nationally and locally, and it's that issue of non-engagement and professional curiosity around that non-engagement. So we read in the report that both parties were reluctant to engage, and indeed at one time Daniel declined and was discharged from CAMS. And I just wondered as a board, because as I've undertaken visits to services, lack of engagement is an issue. I just wondered how we as a board were assured that our staff exercise that professional curiosity around service users who won't engage with the service.
Yeah, and I think it's a really fair point. I mean, what I will say about this particular case, that there was no indication for either of them that they were kind of appropriate for the CAMHS services that were available at the time. I think in terms of these ones that are based within schools now, I think it is a very different picture. And I agree, Sharon, and I've asked them that question myself, and indeed the safeguarding training, we've included in a whole section on professional curiosity. And, you know, if you kind of just have a little bit of an inkling. The crisis teams now have a very clear DNA policy and the following up and how that's connected. So I think as an organisation, it's something that we are, you know, we have done lots of work around, and we are moving forward. I can see that Chris Higgins in some of the chat has also got comments, so I'm sure Chris will talk about some of the additional work that they've been doing in operational services. Thank you, Chris.
Chris.
Yeah, just picking up on that point, so it's one of these things where kind of separate the two out. I think what's happened is really tragic in terms of the this particular incident. I think what's clear in the report is it wasn't predictable or preventable in that respect, certainly not from a mental health service perspective. However, picking on your point about how do we support people, how do we do that professional curiosity, what we're working with our local commissioners and other partners in the system is to, following the lead of the adult mental health transformation, is about how do we come together as partners across the system, that integrated working around people in neighbourhoods, in the places that they live, connecting schools, primary care, secondary care services, local authorities and neighbourhoods and communities, so that we can actually wrap services around somebody. We want to move towards, as a system, certainly as an organisation, a no wrong door policy, a service for everybody of some sort. That might not be us delivering that as an organisation, but making sure that when somebody's got an identified need, they get some kind of service offer from the system, and that works in a joined up way. So that is certainly what we're working on. It's the ambition for mental health, learning disability and autism services, and definitely that includes kids as well.
Thanks, Chris. I'm not sure that we've got any more questions or comments, so just a few from me, Anita, if I may. I mean, the first is that an absolutely tragic incident, and you're right, the report is a harrowing one, and it took me 2 or 3 goes to manage to read it all and keep myself intact. Absolutely, I think the board should acknowledge that our services have moved on from the time of the incident, but even now, with a different portfolio and a better portfolio of services, we probably wouldn't have been able to stop it happening, very sadly. And to Chris's point, all of this is about mobilising the right multi-agency response to vulnerable children and families, and for LPFT, it's about making sure that we're playing the right role in that multi-agency response. And I take significant assurance, Anita, from what you say and from what Chris has said, that we are playing the right role in that multi-agency response. So, notwithstanding how harrowing and tragic it is, I think in terms of our role in that system, we're getting it right, and we continue to get it right. Anita, thank you, and thank you for presenting that this morning. I think that's probably the right time to have a quick break, to go and make a cup of tea or coffee or whatever, because I think all of us might want to step away for 5 minutes after that item. So it's currently 10 o'clock. Shall we reconvene at 10 past? Okay, it's 10 past 10. Thank you everybody for rejoining us. Let's carry on with the agenda, and item 3.1. Tim, which is yours.
Thanks, Chair. So Tim Harry, non-exec director and newly appointed chair of the People Committee. I'd just like to draw out 3 themes on the report and then invite Jane Marshall to make further comment. The first observation is really around, we discussed a lot improving the data availability, which will give us better decision making and assurance. And a key example of that was better data for the recruitment and retention aspect, and in particular the forward look, so forecasting where we're going to be as a result of the various mitigations happening. So whilst we won't discuss that in fullness until the next People Committee in December, what we will see is the emerging developing data on a month-by-month basis with the performance integrated performance report for the organisation. The second comment really was picking up on a sense of ambition against by committee members against a number of the key priorities and issues, whether that's race equality, other aspects of EDI, or the gender pay gap, which is the next paper on the agenda, and you'll pick up a sort of sense of intent around that. My final comment really was around the use of the board assurance framework, as we previously discussed, how we're going to use that as a key tool in the board and also the committees. My observation is that I thought it worked really well. We used it to set out the key risks and the mitigations. We went through the papers and then reviewed the discussions that we had and any impacts on the level of assurance that we felt we had obtained. And that will obviously be picked up later when we talk about the BAF. But Jane, any further comments?
Thank you, Tim. Thank you, Tim. Jane Marshall, Director of Strategy and People and Partnerships. I have nothing to add to what you've said. I think other than to say it was a great meeting where I think we focused our attention, particularly through the way we used the board assurance framework, on our key risk, which is recruitment and retention. And it was Tim's first meeting, so thank you for your support in steering us through quite a complex agenda. The one thing the board does need to approve today is the decision the People Committee took to publish the workforce race equality data and action plan, similar for the workforce disability equality standard, and the data for the gender pay gap, not the action plan. And those were delegated approvals from the board last time we met, Chair, if you remember, the first 2 of those. Thank you.
Thanks, Jane. Thank you, Tim. Questions or comments for Tim or Jane? I've not seen any. A couple from me then, if I may. The first is you touched on the kind of workforce forward planning, data element. Tim, really pleased to see the work that's going on that. Jane, you and I have had conversations around that too. From my perspective, we really need to keep that on track, and it really does need to deliver in December. And I think that from the board's perspective, we need early sight of what that workforce pipeline looks like, where the continued pressures are. So the sooner we can get some product from that for board to see, because it is, I think, our single most significant risk that as an organisation we're carrying. And I feel the need to have some of that really well crystallised and brought together for the board. So look forward to seeing that. Second observation is one that I kind of bring a comment forward from the Chief Executive's report a bit later in the agenda, because it's relevant to the People Committee, and that's around international recruitment. In her report, Sarah talks a bit about the immediate success we're having. I think it would be really helpful if the board again had early sight on how our plans are crystallising around international recruitment, both in terms of how successful we're being, how the process is going. But from my perspective, one of my priorities around all of this is to make sure that we settle people well into the organisation and into the country and into Lincolnshire. And I've Ananta will recall that she and I have had conversations about how we use that as a really important measure of and really important symbol of the way in which we welcome people into the organisation. So I'd welcome some early sight for the board, both in terms of process and that kind of settlement element too. So if we can get something brought forward on that sooner rather than later, I'd welcome it. Thank you. And so the final point then is whether or not the board is content to agree the publication of the data that you've identified, Jane. So if anybody isn't content with that, then please shout. I'll take silence as consent. And Jane, sorry, you have a comment, or have you addressed that? Sorry.
Sorry, Kevin. I just wanted to say, Jane Marshall here, Director of Strategy, People and Partnerships. Sarah and I have had a conversation this morning because you're right, international recruitment for nursing is raised in Sarah's report and generally. So Sarah has some additional information. I'm sure she'll feed in to that. But yes, we will give the detail to the board on how that's going in a written paper at the next meeting. Thank you.
Fabulous. Thank you, Jane. Okay. No one's saying that they're not content with the publication of the RES and WDES action plans. So take it that the board's content with that. Jane, thank you very much, and thank you, Tim, for your first chairmanship of the People Committee in the report. It's really helpful. Thank you. Shall we move on then, Jane, to the gender pay gap, which I think is yours as well?
It is. Thank you, Chair. Jane Marshall, Director of Strategy, People and Partnerships. This paper is about the gender pay gap report in our organisation and has been considered by the People Committee and put forward for approval by the Board of Directors today. I'm not intending to go through the detail, but I would like to focus on the executive analysis and the judgments we've made, which my colleague Tim Harry, who's chair of the People Committee, referenced. The first is a very clear message that our data on the gender pay gap are showing a disparity between males and females in the average hourly rate of pay against each of the 6 areas that we are required to provide data on. There is an action plan amended to this report that will help us address that, but it's a significant challenge for the organisation. Bearing that in mind, as chair of the People Committee, Tim Harry talked about having some ambition around this agenda, and we have developed a draft statement of intent for the board to consider as part of this paper. But I think that ambition is important to have on this report because the differences are significant, and I think we need to ensure that the actions we take on this challenge are in line with our values and behaviours that we cherish and treasure as an organisation, so that there are no unintended consequences of any actions we take, but also we make sure we connect in with our staff, with our people on some of the challenges they want to see and the experience they have. I'm particularly concerned to hear from females, from women who are affected because of their childcare responsibilities and other caring responsibilities. So with that in mind, Chair, what we've got today are a set of recommendations for the board, which are about confirming the board's commitment to eliminate or improve the gender pay gap and improve gender pay equality over time, recognising that there are no quick fixes, but there is the need for a serious conversation and engagement exercise on how we do some of this. The second recommendation is to prove the publication of the data, because we're required nationally to do so, as are all organisations with employee numbers of over 250 people. and to approve the action plan, noting that that doesn't require national publication, and we will be iterating that through our engagement processes as we go. Thank you, Chair.
Thank you, Jane. It's a very self-explanatory report, even if the headlines are not quite as welcome as we maybe like them to be. Tim, you have a comment?
Yes, it's only a quick one, and it's obviously fully supportive of this, but I guess as with a number of other areas, we just need to be mindful of capacity to deliver these actions. And I think, you know, that's my sort of word of caution. We just need to keep an eye on that.
Yep, I think that's a perfectly reasonable observation. Any other questions or comments? So there are the recommendations, Jane, are that we approve the action plan and its publication, to approve publication of the results, and to confirm as a board that we're committed to eliminating or mitigating the gender pay gap. Does anybody disagree with any of those recommendations? I think I'd be very surprised if people did. I have and I'm really reluctant to engage in drafting by committee, Jane, because it's always a bit of a fool's errand. But on the statement of intent, I wonder whether it would be clearer if the first sentence ended at workforce. So we just said the trust fully commits to taking action to eradicate pay inequalities in our workforce, full stop. And we don't mention the stuff about equal pay for jobs of equal value, because that's what the Equal Pay Act requires us to do anyway. And I wouldn't want us to, you know, go into this suggesting that we're breaching our legal obligations. So I think we just end it there, and then we do this in line with our values. That's a much broader and more sweeping commitment, I think, but a useful one, if you're happy with that. Excellent. Good. Thank you very much, Jane. So we can take it that the board has agreed your recommendations there, and we'll move on then, if we may, to risk. Back to you, Anita. This is the Anita and Jane show this morning, isn't it?
Well, I'm going to quickly introduce this and pass it on to the rest of my colleagues, so it'll be not as much of me. So this is the organisational risk register. As a trust board, we are responsible for assuring ourselves that, and the public, that the risks are identified and that we have a robust risk assessment process. So in terms of the risk register for public board, we have 5 risks that are in the extreme values and 7 that are in the high value. So we have 12 in total that have been reported to us. There are no new risks that have been added since last time we met, and none of the risks have been closed. There has been an increase in the risk scoring of one of the risks, and one has been kind of downgraded and moved into the operational divisional risk register. So as I've said, you know, obviously the risks are owned by each has an executive lead for each of them, and I'm sure the executives, if there are any specific questions, will be happy to answer those. What I will say going forward is we are looking at the presentation of the risk register. I'm conscious, Kevin, you and I have already had a couple of discussions. It can at times become quite difficult to read. So I'm going to meet with the team, and we're going to put 1 or 2 examples together and work on how it can be presented, and potentially send those round to colleagues. I make no promises it will be completed for the next board in 4 weeks, but we are going to work on it, because I think it's important that everybody that's part of this meeting is engaged in that process on the presentation of this report. So I will pass around to colleagues. I just wanted to take presenters' prerogative and kind of take advantage of talking to one of mine first. And the risk on the risk register that is around mine is around the Philip training, which is the physical healthcare training. We've heard earlier, you know, through the infection prevention control policy, kind of around catheter care and around some of the SIs, the importance of the combination of physical and mental health care. This was something that we had to step down in COVID times because of the face-to-face nature of this. And however, it is back up and running. I am having daily update. I'm not having daily at all. I'm having 2 weekly updates on DNA rates, being able to support operational services to release staff on this. So it was discussed in People Committee. We are monitoring this very carefully, and we are starting to see quite a sharp increase in the compliance rate. So it's just to provide assurance, really, that this truly is on an agenda, and I'm monitoring this really closely. But other than that, I'm happy for other executives to talk to their risks, or indeed take any questions from any colleagues on the call.
Thank you very much, Anita. I think, Chris, you're in first.
Yeah, thanks, Kevin. Yeah, Chris Higgins, Director of Operations. It was just to flag that on risk 169, which relates to registered nurse recruitment and quality improvements on Charlesworth Ward. That risk is currently being reviewed, and notice the target date was today, actually. But that risk is currently being reviewed, and the situation has improved. The risk is now reduced. It's likely that we'll keep that on a divisional level for a time, just to make sure that the improvements that have been put in are sustained, but it's likely to come off this organisational level risk register and be monitored at a local level. But certainly the situation has improved, staffing levels have improved, and some of the quality work seems to have taken good effect, and that's been monitored by the executive team, and the paper went there last week setting that out.
Thanks, Chris. That's helpful. Thank you. Any other questions or comments, either from risk holders or from other board colleagues? Doesn't look like there are. Anita, I mean, I thank you for undertaking to go away and have a further tweak with, presentation. I'm less worried about the speed with which that happens than we get it right, and presentation in this is kind of it. For me, it's important because this needs to be a document that's easy for people to navigate and easy for people to, kind of draw conclusions from, and a document that works for us as a tool. Before we move on, I think Andy's got a question that he'd like to ask. Andy.
Sorry, thank you, Chairman. Sorry, it was only a quick one. It's about the risk 144. Andy Spring, non-exec director. The target date I noticed was today, basically, and I just think we still have the same problem. So my perception is I just want the exec team to just have a look at that risk and review it if at all possible.
Can I come in?
Thanks, Andy. Yeah, please do, Ananta.
Yes, thank you. Ananta Dave here, Medical Director, and thanks for, yes, I did notice the date. I think it would be fair to say that although there are movements in a positive direction, I wouldn't really be comfortable in terms of, articulating the risk in another way. So you're right. I think past this date, we will be reviewing it and seeing what it is that we would like to give as a narrative, and capture in some granularity what it is that has been happening. So I will take that on board, and that is part of the plan. Thank you.
Thanks, Ananta.
Thank you, Ananta. If there are no other questions or comments, I suggest that the board receives the report. Oh, Di, sorry, you just popped up just in time.
Sorry, Kevin, Di Bailey, non-exec director. Right. Ananta, can I just ask, because I think we've added risk 158, sorry, Anita, to the organisational risk register, which relates to some of our provision, again, around young people. And given the conversation that we've had previously in the meeting, both in relation to the, re-provision of some of our CAM services and the serious incident report that we've considered, I just wonder if you could, give a bit of reassurance, really, or just explain how we're going to manage that going forward.
Yeah, thank you. I mean, in terms of providing the right clinical staff and risks and skilled workers, I think then we've had positive movement in terms of recruitment and interest shown in our camps posts. And so we have got either substantive staff, or although we do have locum agency staff, they are long-term and are able to provide some continuity of care. I think keeping in mind the various changes that are happening in terms of increased focus on community provision, our taking on more of a trauma-informed care approach. I know that we've got new services coming in within CAMS, which are about providing that evidence-based trauma-informed care in the community. I think the issue is about making sure that the medical staff and all the other multidisciplinary staff within teams are working together very closely at team level. So the core CAMS team, the crisis team, the home treatment team, and the CAMS eating disorders team, I think all of them working together. So I see positive conversations in terms of joint working, some of the learning that has come out of recent feedback, engagement events, executive director and non-executive director visits. So I think I see movement in the right direction towards that, and we are very cognizant of making sure that with increasing provision in the community, we do need to have good complement of skilled and experienced staff. We've had positive results in our international recruitment as well, and in our clinical academic posts. So when I next articulate the risks around medical recruitment, I hope to be able to tell a more positive story. Thank you.
Okay, thanks, Chair.
Thank you, Di. Thanks, Ananta. Chris, you have a comment.
Yeah, just specifically around risk 158 is that we're actively engaged with the local authority and the CCG and partners around looking at the long-term transformation of children and young people services in Lincolnshire. And that's a really healthy relationship, and we're currently looking at how we're going to transform services, recognising and building on the work that we've seen in adult community mental health and the benefits that that's bringing in terms of building that community capacity and rapid services around schools and primary care. And so at the moment we're just in some conversations about setting out a plan for an ambition for transformation of children and young people service in Lincolnshire. It's likely to take over probably another year or potentially 2 years to get there. As we know, transformation takes some time, but there's an absolute commitment to working together to get that right for children and young people. So I'm hoping to be able to bring some more updates and assurance through in the kind of coming months as we get to know a bit more about that programme of work.
Thanks, Chris. That's helpful. I don't want to move on prematurely, but that's been a good discussion, both around a number of the risks and the way in which we present it. Don't intend to prolong that any further. So on behalf of the board, thank you, Anita. We take note of the risk register and the further work that's being done around both the totality of the register and those individual risks. So let's move on. If we can, I think the next item, Sarah, is the Chief Executive's report. So over to you.
Thank you, Kevin. I'm Sarah Connery. I'm the Chief Executive here at the Trust. So here's my report for this month. Just to say, I think a general theme is things are extremely busy. It's been a very busy month, not just because we've got the board and our annual public meeting, which was fantastic, but we've been working on our HSJ Mental Health Trust of the Year presentation. So a massive thank you to Ananta and Jane and the team for working together and pulling that together. So everybody keep their fingers crossed for November, when we'll hear if we've been successful. If we haven't, it's been an absolutely fantastic process, I think, for us to just reflect back, not only in the HSJ presentation, but also through the APM as well, in terms of what's actually been achieved at the Trust over the past 12-18 months. So a really good sort of period of reflection. Things are extremely busy in the NHS, as has been heard quite a bit this morning, is the word unprecedented. So particularly in acute pressures and social care. So recruitment in social care is becoming a particular pressure in terms of flow and discharge through the acute system. We've all seen what's been happening at the petrol pumps this week. We've still got issues around blood vials for testing and impacts of Brexit on various elements of the supply chain. So sort of as we're moving into autumn and the weather starts to turn, I think it's more important than ever that the system pulls together, gets innovative, pools resources wherever possible to get us through what will inevitably be quite a tricky sort of 6 months. That said, I'll move into the body of the report. So first of all, I didn't want to not acknowledge my appointment to Chief Executive as a real person, as Kevin helpfully put earlier, in 3 dimensions. So I just wanted to formally note a thank you for everybody's kind words, words of encouragement and congratulation sort of through the process. And also to thank my executive colleagues for all their hard work and support, not only during the acting up period, but also latterly since my substantive appointment. So I just wanted to formally acknowledge that, if I may. Really looking forward to continuing to work not only within LPFT, but also working with my system colleagues to deliver even better patient care in the future. And I've been quite busy since substantive appointment, sort of building on some more connections with district councils, Active Lincolnshire, East Midlands Ambulance Service, in terms of what we can do to connect more parts of the system to each other to get better outcomes. I always ensure that we cover COVID-19 as part of the report. So we've now moved into phase 3 of vaccinations, and we've had real positive outcomes in Lincolnshire through phases 1 and 2 of the vaccination programme, and we're working really closely together on phase 3 as well. So members of the exec team already had their flu jab, so encourage others to get jabbed, not only with the flu vaccination, but also with your COVID booster at an appropriate point as well. Safe, as Anita said in our infection prevention control report, safety is our priority, but we're hearing a lot from colleagues and services that they're really keen to get together face to face, not only for sort of group work in a clinical setting, but also to build that team spirit back up. We've invested in a lot of new services. We've had a lot of new starters over the COVID period, and I know members of the board haven't physically been in a room with each other, and the same applies out there in services as well. So what we said was that we would review in October. That was always our goal in terms of the balance of digital versus face-to-face. But given the stark disparity between the healthcare settings and what's actually happening there in people's social settings, we pulled that forward. And last week, the executive team, as part of Gold Command decision making, agreed for face-to-face meetings that we would approach a risk-assessed framework sort of approach, where teams who want to get together face-to-face or want to put in some clinical setting group work can put in a risk assessment. It goes for authority. There's a clear audit trail. As we said, all of our decision making will come under scrutiny. So we want to make sure that we're sort of logging all of those decisions. So that was actually instigated this week with a clear framework and process for our colleagues to use. This was something that was built up with our health and safety and our infection prevention control lead together to make sure it was robust and appropriate. Also on COVID, so from the 11th of November, it will be law for anyone entering a Care Quality Commission registered care home to be fully vaccinated against COVID-19. The only exemptions will be for those who have a medical exemption or children under the age of 18, friends and relatives visiting a resident. So we've been working very hard to get together our sort of position statement in terms of the staff who are fully vaccinated. And we're assessing that next week in terms of whether there will be, it's manageable in terms of the staff who aren't vaccinated, given it's currently not mandatory, and those people who need to actually enter the care home. So we'll be working together with the services next week to pull together a really strong situation report on that. A key question for us will be, of course, what do we do in terms of future recruitment to some of those posts going forward? In terms of service demand there, it is mentioned in the sustainability meeting minutes at 6.1, but we've obviously been tracking quite carefully any impacts on referrals through COVID and beyond. and we've just wanted to make sure that any sustained and significant increase in referrals to our services is well tracked, and we have a plan to address that. And in the report there, you can see that we've highlighted the various services where we have seen those increases. What we're going to do is refresh that piece of work for September information, and then that will be available to come back to the board in December, so that all of the board members can see exactly where we are. So, you know, at the minute we've sort of got the data up to June, but we're seeing increased pressure through July and August as well. So we want to make sure that we're constantly refreshing that piece of work. For a lot of the areas, we have got plan mitigation in place, so additional investment as part of the long-term plan. You know, we're talking about international recruitment, etc., to increase our staffing capacity. But at some point, we need to understand what this will actually do in terms of our waiting lists. And as we'll get onto in the integrated performance report, we're already seeing that in terms of core CAMs. When I was writing the report, I realised it feels like an age away, but on the 23rd of July, we had the report from the Care Quality Commission, who had carried out a mental health act inspection on the Francis Willis unit. It was a really positive response, and there were actually no actions to take as a result of that visit, which certainly from my perspective, I've never actually seen in a CQC report. So massive thank you from myself to those staff and service users and carers who were involved in that inspection. Comprehensive spending review, so people be aware of the information that was released on the 7th of September in terms of the investment that will be going into NHS and social care over the next 3 years. A key point for us to just keep our eye on is around the mental health investment standard, and I'm pleased to say that the indications are there that the MHIS is here to stay for the foreseeable. And we wait for the white paper on social care reform, given my earlier comments about how the social care sort of market and challenges there are impacting on discharge and flow through all of our services. We sort of wait eagerly in terms of that white paper, which is due later on this year. In terms of regional, we are being sort of heralded as a bit of a forerunner in terms of our international recruitment, and you'll see from the report there that we have been successful in terms of taking up some candidates. I think it's fair to say, even though this is our biggest risk, that we want to take, try and think of the right turn of phrase, small but well thought out steps in terms of our approach to international recruitment. We want to make sure that people have got really robust pastoral support when we are taking people on and welcoming them into our services and into our country. So we did say 4 originally, for example, for mental health nurses, and we've been able to successfully appoint that. And there is a discussion at the executive team next week about if we have actually had some really good solid CVs come through, whether we're in the position where we feel that we can extend beyond the original 4. And as Jane has said, we're happy to bring a paper back in November board to give a bit more of a picture on what's happening with international recruitment. But thank you to Jane and the team for really sort of grasping the nettle on that key area, and others in the region are really interested to hear about what we're doing on that agenda. As Kevin said in his opening comments, we've got a lot of forward movement on integrated care system. You could drown yourself in guidance documents and do nothing but read them all. I think for us, it's about staying really focused on the outcomes, particularly for mental health, learning disabilities and autism. And we've got some more discussion time on that in part 2 of the board today. In terms of no excuse for abuse, I just wanted to formally acknowledge this, that there is growing evidence that NHS staff have been experiencing an increase in unacceptable abuse through the COVID-19 pandemic, and this is through from primary care all the way up to sort of tertiary healthcare services. So as a Lincolnshire system, we've launched a No Excuse for Abuse campaign, which is just about that we won't accept our staff being subjected to any abuse, that we expect people to be treated with kindness and respect when accessing local health and care services. So please do use social media channels where you can to promote that. In terms of LPFT, we continue to push forward with our community mental health transformation. I gave a presentation on this to the Health and Wellbeing Board on Tuesday. Lots of interest in what's going on. Recruitment is continuing at a pace, and the service is starting to deliver more outcomes. So we have got this coming to a future board development session, but we're really starting to fill those posts now, which is great to see. Also want to just acknowledge there our newly qualified mental health nurses, so a massive congratulations to 25 mental health nurses who've gained their qualifications during one of the most challenging times in the history of the NHS. So we're delighted to continue to offer those placements and support, and in the report there it talks about where those staff will be allocated in services. So just want to say a big welcome to those to our trust. So just in closing, Kevin, you talked about it in terms of your opening statements as well, that I'm absolutely delighted that we're starting in a safe way to be able to get out as non-executives and executives together as well, for us both to have time outside of the board setting and the subcommittee setting to be able to sort of talk and share stories, hear from frontline staff in terms of how it's feeling. And I just want to say it's humbling as ever to hear from staff in terms of their commitment and enthusiasm, which shines through in all of the sites that I've visited, and how with increasing demand, the disappointment that they can sometimes feel when they can't provide the level of service that they can. So in terms of the earlier conversation about patient stories and hearing about when we're not quite getting it wrong, and a bit more of a focus in terms of that increasing demand. I just want to say a massive thank you to all of our staff for all they do each and every day. So I'll shut up at that point. There was quite a lot in it, and I'm happy to take any questions. Thank you.
Thank you, Sarah. Thanks very much for that really comprehensive report that just, I think, demonstrates just how much stuff's going on at the minute, and how busy the whole both you and the rest of the exec team are. Colleagues have any questions or comments for Sarah? I've got a couple. I can see Tim's busy typing, so if I busk for long enough, a C will come up. Tim.
Sorry, I should have typed a bit longer, Chair, because it was a one letter. Just to pick up on your final point, Sarah, about site visits and so on, and I am genuinely not amazed, not quite sure what the word is, but from previous experience of other organisations and walking and talking, I have not seen a level of enthusiasm, professionalism and vocation as I've seen with all the people that we've met on. I've only done 3 site tours, but if that's reflective of the total organisation, it's staggering.
Thank you.
Thanks, Tim. A couple of observations from me, Sarah, all of which I've pre-warned you about, so not expecting immediate responses on any of them, but I think on infection control and bringing back face-to-face meetings, it would be nice to have some time frame around that and at least be able to give people an indicative idea of what we currently think, all other things being equal. I think that would be helpful. On your comments on service demand, I know we've shared information elsewhere, for example in the Health and Wellbeing Board, about what those pressures look like in terms of demand by service line and what our response is. I think it would be really helpful to share some of that with board so that we've got some some visibility from our perspective around where we're feeling increased pressure and what we can and can't do about it. I think that would be really useful. And again, the final thing is the changes to care home rules, and it would be useful to know when we'll have worked through the implications for LPFT on all of that. I don't propose that you bring that back to board, but it's something maybe that we can cover off offline if colleagues are happy with that. And my final two more observations, forgive me. My penultimate one is, the old-fashioned part of me, which is quite considerable, there's always been a strong believer in management by walking about, and it's really difficult to manage by walking about when you can't walk about. So it's good that in a safe way we're starting to be able to do that. And my final observation or comment is just to echo your point, Sarah, about vaccination, and to encourage people to go out and get their influenza vaccination, and where they're eligible, get their COVID booster, please. Sarah, thanks very much for a really good report.
Thank you.
I think the floor's yours too for a typically brief NHS National Document.
Thank you. Sarah Connery, Chief Executive. So, NHS Net Zero. So, colleagues may or may not be aware that a year to the day, actually, it's almost like I planned it, wasn't it? So, a year to today, the NHSCI made a commitment for the NHS to be the first healthcare service in the world to achieve net carbon zero. The target for direct control is 2040 for direct emissions produced by the NHS, with an 80% reduction by 2028 and 2032. And for broader emissions, so this is in terms of sort of supply chain, not completely within our control, is net zero by 2045 with an 80% reduction by 2036 to 2039. It seems like a long way away. But when you look at some of the drivers in terms of what is actually driving our carbon emissions, particularly in terms of some of the age of the estate, that is actually a massive challenge for us to achieve. So the paper for board here today is just to sort of be really clear with the board in terms of what those ambitions are and how it feeds into our system, and more importantly as well, our organisation in terms of what we need to do. And we've latterly put in some additional governance into the system in terms of really driving this agenda forward. The climate emergency is a health emergency, and in terms of the ambitions that are set very clearly to systems and organisations, not only is it about meeting the NHS's net zero targets, it's also about our adaptability and resilience to the impacts of climate change, so extreme weather events, for example. So this is also about building a more resilient healthcare system that understands and is responding to the direct and indirect threats that are posed by climate change. In addition, it'll be a real focus on the health inequalities that are driven by climate change as well, in terms of air quality, for example, in urban areas. So it's absolutely important that we keep this front and centre as one of our key priorities. So if you go to page 2 on the report, you can see the sources of carbon emissions there by proportion of NHS carbon footprint plus. And I think it's quite fascinating to think about actually in terms of the carbon footprint, that most of it is driven by medicines, medical equipment and other parts of the supply chain. If you look at staff commute, for example, it's only 4% of the total. So I think it's just really important to keep that sort of diagram in mind when thinking about our strategies to deal with this going forward. As Kevin said, there is a rather lengthy NHS strategy that goes along with this, but I would plead, if you were going to look at anything, if you look at figure 1 at the beginning of that document, that really very clearly sets out the areas that we need to address in terms of the direct and indirect impacts on carbon footprint. So the targets for the systems: on the 24th of June, all chief executives received a letter from NHSCI which highlighted the key tasks for systems and providers. So we all need a board level net zero lead, and also one for the system, which I'm happy that I've been nominated to take on that mantle on behalf of the system, but we still do need a board level net zero lead. There's also going to be a lot of comms and engagement campaigns in terms of getting all staff and all leaders to make a pledge in terms of what they personally can do to achieve net zero carbon. A key ask for the trust is to sign off a 3-year green plan by the 14th of January. And we're just working through then in terms of availability, which board that will actually be coming to for sign off. And then what we need to do is collate all of those together, and we need an ICS green plan that needs signing off and submitting by the 31st of March next year. So lots to crack on with as we're going through a busy winter and all of the other pressures that we've talked about today. So in terms of governance, we've set up a Lincolnshire Green Group, which feeds into a regional green group, which feeds into a national green group. An LPFT already has its own sustainability group that's set off. So I think it's fair to say we were a little bit forward thinking in this, and we've had a sustainability lead in the trust for a number of years now, working on this agenda. And on pages 3 and 4, we can just highlight some of the traction that we've gained in terms of taking that agenda forward. And we'll be definitely having a conversation about this in the Norton Lee business case later on today, because we have got the ambition to make that site net zero, which is fully electric without the need for gas boilers, but that would come with a capital premium. So what we're starting to do in terms of our investment appraisal framework is build in environmental sustainability as part of our assessment protocols going forward. So in short, climate change does threaten the foundations of good health with direct and indirect immediate consequences for our patients, the public and the NHS. The NHS ambition for net zero carbon is very challenging, but an imperative ask for each healthcare system. And the trust is required to nominate a board level net zero lead. It's suggested that that be me, given I'm holding the sort of system lead role, so I'm already connected into that governance structure. And as part of the recommendation, the board's asked to acknowledge the progress made to date and to expect the trust 3-year green plan for ratification. I put there at the January 22 board, but given the submission is 14th of January, we'll have to have a little think about how that might look in terms of approval. So I'll stop there. There's quite a lot in the report and in the appendix, but I'm happy to take any questions. Thank you.
Thank you very much, Sarah. I've got a number of colleagues who are keen to comment, starting with Tim.
Sorry, Chair, that's an old hand.
Is it an old hand?
Yeah.
Okay. Well, I think Sharon is next then.
Thank you, Sarah. Sharon Robson, non-exec. I just wondered, in terms of the system oversight, whether consideration had been given to research as an enabler, and particularly around that. There's a big area around medical equipment and medicines and things like going from disposable to reusable. And I thought it would be relevant fairly early on in this piece of work to get that research aspect engaged, so we can demonstrate that we've made some improvements in health and health inequalities.
Yeah, thank you. That's a really good point. So there is a separate medicines group that's set up as a subgroup. So there's a sort of a number of pillars that feed into the group, and Lincolnshire doesn't perform well in terms of its impact of certain medical gases and inhalers. So it's actually second worst in the region for desflurane. So there are some quick wins that we can achieve through that. So we have got sort of medicines management feeding in. Brilliant point about research, and we had considered, once we've got a few more meetings under the belt, to bring potentially the University of Lincoln in as well. And as you say, to help with some of that data analysis, because at the minute, actually building what our carbon footprint is not an easy task. So there's something there around using the University of Lincoln for research and business intelligence. So I'll take that into the next meeting. I hope that answers your question.
Thanks, Sharon. Thank you, Sarah. Philip.
Yes, thank you, Chair. Philip Jackson, non-executive director and also chair of the Sustainability Committee. I just wanted to support everything that Sarah had said in her comprehensive introduction to this. The Sustainability Committee has taken on the mantle of overseeing the work that we're doing in this area in a more detailed way, and I'm sure that every member of the Sustainability Committee has read every word of the not inconsiderable amount of NHS guidance that has been put forward on this, and will continue to do so, because I'm sure we'll get even more guidance as time goes by. But on a more serious note, the fact that we appointed a sustainability lead some time ago, I think means that we've done a considerable amount of work in this area already, and the Sustainability Committee has been impressed with a lot of the initiatives we have taken and are planning to take, and we'll continue to have significant input into that. As Sarah rightly says, of course, we've got a report in part 2 of the agenda, a business case, and part 2 of the agenda for the developments at Norton Lee, and we're talking about a potential 10% capital premium on that to make that site more sustainable, and that's something that we'll be considering later on the agenda. But basically, I think as a trust, compared with others in the field, we're making quite good progress in this area, but obviously not something ever to be complacent about. Thank you, Chair.
Thank you, Philip. So, Sarah, you're inviting the board to note progress and to expect the 3-year green plan for ratification at a future meeting.
That's right.
I think the board is happy to do both of those. So thank you very much. Thank you for the kind of obvious passion that you speak to this with. I think you are the right person to lead on this, because that passion will take people with you. So thank you.
Thank you.
Philip, I think it's back to you for the next item.
Yes, it is. Yes, thanks, Chair. Philip Jackson, Non-Executive Director and Chair of the Sustainability Committee. I just really wanted to introduce the minutes from the August meeting and the highlights and exception report. Just mention 1 or 2 key things in there, if I can, just bring them to the board's attention. First of all, the sustainability strategies update. Although there's been some further delay on that due to capacity issues, we are making progress on those, and the draft strategies will be presented to the committee for consideration at its next meeting in November prior to presentation to the board. So I think we're satisfied we're making good progress with those. We've already talked earlier on the agenda today about international recruitment. That's been mentioned a couple of times, and there was some extensive discussion about that at our meeting as to how that can assist in addressing the current significant workforce gap. And we also recognise the importance of a welcoming and supportive environment for new overseas staff, which again I think has already been mentioned earlier on the items on today's agenda. We also took quite a detailed look at COVID-related mental health activity, the increased referrals within certain services and specialties across the trust, and we also acknowledged the increased level of investment that's already been agreed with commissioners in some of those areas, but clearly that's something that we need to keep an eye on and will continue to monitor. And again, I know that Sarah mentioned that in her chief executive report as well. Linked in with that, we looked at the operational service changes that have been brought about as a result of COVID in terms of retain, revise and revert, and you'll see some more details about that in the minutes. It was also suggested that it would be beneficial to present this document to a future joint meeting of the Board of Directors and Council of Governors, just so that our governors are fully sighted on some of the changes that we are making as a result of COVID over the last 18 months. And last but not least, we looked at the eradication of dormitory accommodation and the potential new development on the Boston site at Norton Lee, and we agreed that we would have a special meeting in September to discuss the business case for that, which we did, and that in fact appears on part 2 of the agenda for today's meeting. So I'm happy to take any further comments or questions, Chair. Thank you.
Thank you, Philip. Any questions or comments for Philip? I can't see any. Philip, thank you very much. The board notes your report, the highlights and the exception report. Very grateful. Thank you. Mark, the moment you've been waiting for all morning. The integrated performance report. The floor's yours.
Excellent. Thank you, Chair. So good morning, everyone. I'm Mark Platts. I'm the Acting Director of Finance and Information for the organisation. So just here today to present alongside Chris Higgins and Jane Marshall our integrated performance report for September. We are actually using July data, so it's important that we get the data fixed at a point in time to give us accurate reporting. So it is July data in this report. Before I sort of touch up on the National Oversight and Trust Performance Metrics section of the report, I just want to thank board members and members of the public and the organisation that have helped look at the development of our integrated performance report. So we have taken all the feedback on. We've had some real good discussions around that, and you'll start to see those sort of noted changes coming through reports in the future months, really. So big thank you for that. It's really going to help shape how we effectively report data through here. If I can just pick up on a couple of the National Oversight and Trust Framework metrics. Firstly, if I can start with metric 11, which is our physical healthcare checks for our early intervention services. So now we've got the team fully established on that one. We're making some really good progress on that. We've actually increased compliance from 75% to 89% in the last quarter alone. So we're fully on track to deliver our planned compliance by November. So great work by the team on that, really making a difference. In terms of metric 15, which is our improving access to psychological therapies, recovery rates, although performance has been hovering around our compliance target of 50% over recent months, we have slightly dropped down to 47.2% this month. Now, obviously, recovery is a very key part of our focus. It's really key that we can work with our service users to allow them through the pathway and get them back on to live normal, healthy lives. So our service managers and clinical leads are now undertaking a deep dive across the service to understand what's happening across there, and we'll hopefully see some metrics performance in the next future months, and we'll keep an update through the report so the board and public are aware on the progress of that one. The final one I did just want to touch on as well. It does feel like we've mentioned this one at many board meetings over the last couple of months, but our consultant-led referral to treatment waits under 18 weeks, so that's metric 29. Acknowledge that we haven't met our initial target completion date for that, but as Amanda mentioned earlier on, we've done a lot of work to improve recruitment across services and allow consultants to work on this. So we are seeing a marked improvements in our metric achievements on that one, and we are now planning to report compliance in December, which, just for confirmation, will be October's data. So we are seeing a really good progression on that one. So hopefully, come October's data that we report in December, we'll see compliance on that. So happy to take any questions on that section, or also happy to hand over to Chris if there aren't any. Thank you very much, Chair.
Thank you, Mark. Any questions or comments before we move on to Chris's section of the report? I can't see any, so Chris, away you go.
Thank you, Chair. Yeah, Chris Higgins, Director of Operations. Normally I'd go through each of the divisional sections and kind of pick out highlights, but and people got a chance to read that, and you know, hopefully because people can see the good work that's in there. I think just what I'd like to highlight is a couple of things. There's some outstanding performance in there across some of the services, particularly if we think about the context in which we're operating. We're still in the global pandemic and all the pressures that brings, and there's some excellent performance. What you'll also see there, though, is what appears to be a theme around increasing demand on services that sit in waiting times, and unfortunately that's not unexpected. We've all been talking nationally about a COVID mental health surge. We are feeling the impact of that now. It's come to the door of Lincolnshire, and we're seeing more people wanting to access a service than we've done for, well, probably ever before in a number of services. It's most keenly being felt across our children and young people's services, eating disorder services and autism, and you'll see in the report that we're having areas where we're not able to meet that demand, and that's resulting in people waiting longer than we would want them to do. There's a number of mitigations we're putting in place, and that's picked up, you'll see earlier on the risk register, where we've identified the risk and we're putting things in place to address that. Some of that is increased investment. We're working with our commission and our staff to look at where we can increase investment into services. Some areas we've not got that clearly laid out yet. For example, autism diagnostic services, we're still not quite there in terms of understanding and agreeing what's required to completely mitigate that issue. So for the time being, we've got a real pressure at some parts of our services. And even with that investment, we've got to have a bit of a reality check in that it takes time to recruit. We know we've got a lot of posts out there at the same time, and not just us. We've rolled out community transformation investment nationally, so every organisation is trying to recruit all at the same time. What that means is it's going to take time for us to be able to get the capacity into some of the services, for us to be able to get on top of the demand that's coming in. We are looking at alternative things like how we can be more efficient, use of digital technology that might be able to mitigate things and improve our efficiency so we can see more people in a timely way. And you'll see that on the whole, people are being seen, but we're starting to get to a point where that's been breached in a number of areas, those waiting times. So particular issues and concerns for us around children and young people at the moment. We're doing a piece of work, a deep dive piece of work for Sustainability Committee in November to really explore and understand that and what could we do differently to try to mitigate some of that risk. But it's just to say that it is being felt, the services are under pressure. We're doing everything we can and working with staff and commissioners to try to mitigate as much as possible and support people when they're waiting. But we are in a bit of a challenging position at the moment in terms of waits.
Thanks, Chris. That's very helpful. Questions or comments for Chris before we move on to Jane next? Andy.
Thanks, Chairman. Andy Spring, Non-Executive Director. Chris, thank you for that update and for the highlighting the work that's being done. I just wondered what more you would want from the board today to help support you with the work and mitigations that you're putting in place to address the challenges you have around performance.
Yeah, thanks, Andy. I think, helpful. I think we've got some really good and positive relationships with our commissioners in the system, and we're having good, healthy conversations about how do we get maximise the right investment in the right areas. Often, as the case for the service users that we're representing, the voice is sometimes quiet in a very loud system, and I'm thinking of things like autism and autism diagnostic services. We haven't got that right as a system. We need to try to work to improve that, and so I suppose it's just making sure that we're really championing that voice and making sure the needs of those people are absolutely recognised at all levels, and that the appropriate oversight and emphasis is put on those services whilst we're trying to deal with the pressures on A&E and all the rest of it. I just see our job as being able to champion that voice, and as a board we can do, if we work that together on that, we can hopefully make that as loud as possible.
Thanks, Chris. Thanks, Andy. Di.
Thanks, Chris. Di Bailey, Non-Exec Director. A couple of questions from me, if I may. So, firstly, in terms of, what are we doing around the mitigation in terms of the rise that we're seeing, particularly with children and young people? I think the evidence suggests that this is going to continue and potentially increase further. So I'd welcome some assurance really around how are we not just looking at mitigation in the moment, as it were, based on the information that we've got, but also thinking about an upward trajectory of demand going forward. So that's one. And then my second point is what the research is telling us about digital offer to our young people is that really they welcome person guidance with that. So where we're putting in those kind of digital offer, I think there is a real case for saying it can't be digital in isolation. I think that has implications for us on two levels. One, obviously, in terms of the capacity issue, but also I think in terms of capability issue, in terms of that, where's that guidance coming from and how are we training colleagues to deliver it? So again, I'd welcome some assurance that we're looking at those kind of issues in terms of thinking about future planning.
Thank you, Di. Really
Chris,
good points.
Sorry, if I may, before you respond, the first of Di's points, can we link that to my observation on Sarah's report earlier, because I think it's the same point. It's about giving us as a board visibility on changes in service demand and what we're doing to mitigate them both now and in the future. I think it's the same point.
Yeah, and I haven't got an immediate answer to that.
No,
issue.
and I'm not looking for you to have an immediate answer.
No, that's great. That's really helpful. But that's part. I don't want to kind of preempt the outputs of the deep dive work that's going on. That's exactly that. Is try to understand what can we do with what we've got, what we've currently got in terms of pressures, what we're anticipating, and what do we need to do differently. And certainly that work, what I mentioned earlier with the local authority and the CCG about we need to transform services. This is not as simple as just bolting things on the end. Equally, what we need to do is we need to move away from, and I know it's kind of the direction of travel nationally, we need to move away from what we've currently got, which is very specialist, discrete teams all lined up together that create gaps and barriers to be able to flex that criteria based on outcomes and not individual specifications and activity. And that's a cultural shift for us all, both as a provider and commissioners in the system. But that's the answer if we want to be able to provide a better service in the future. Your second point on digital, absolutely. What we're finding, I think there's an assumption made early in the pandemic that young people like phones, so they'll be fine. What we found out that actually the outputs, particularly for our young people, we're getting less effective treatment for some people with digital, and that's when you look at that, it's not surprising because when they come and attend an appointment physically out of home environment, they've got a dedicated focus, they're working with peers in a group. If you're on the back end of a screen, you can switch off, mum's calling for your tea, all those kind of things that distract you. Sometimes, unfortunately, kids are trying to do therapy in an environment they've experienced trauma in, and if you can't take them away, how do you separate the two out? So we're certainly seeing that the digital's great for some people, certainly not for everybody, and that's the bit we're trying to work through now to make sure that we've got the right choices. But absolutely picking up your point, there's a training thing here for staff about how do you maximise the benefits of digital working. I don't think we're there yet. It's on the radar. We need to do something and learn from others around the country around on that, to how do we get the best effect for it for our teams. So but yeah, absolutely, we're on to that.
Thank you.
Thanks, Di. Thank you, Chris. Jane.
Thank you, Chair. Jane Marshall, Director of Strategy. Chris, I wanted to ask you for a comment on the complexity of the commissioning arrangements for children and young people's services and how you think they may change over time as we work to integrate that function into provision. Thank you.
Yeah, so obviously at the moment, local authority lead commissioners for children and young people's services, and as I say, we've got a good and healthy relationship there, but obviously that's different to our adult services who are commissioned through the clinical commissioning group. And so we just need to make sure when we go forward that those two commissioning arms are absolutely directly linked and complementary, and there are points in the pathway. Whilst children's services are specialist and some of our adult services are specialist, there's points in the pathway where it would make sense for those things to be integrated. Primary care, for example, when somebody attends the GP, there are GPC people don't differentiate on age. When somebody attends A&E, they don't differentiate on age, but at the moment we've got that differential, and that might be right in terms of getting specialist treatment, but I think we need to work that through, and there's an opportunity for integrated commission, I think, certainly like community primary care and in those urgent care facing services. So more work to do, and I suppose it's just being open and focusing. What I meant before was about focusing on the outcomes. Is we've got traditionally we've set up contracts where we've got really quite tight specifications for activity and outputs and performance and counting the activity and outputs rather than looking at population health outcomes. And if we can move to that and let our resource and our staff do what they do well, flex to the needs of the people around them, we'll get, in my view, we'll get a better service.
Thanks, Chris. Mark.
Thanks, Chair. So Mark Platts, Acting Director of Finance and Information for the Trust. So to be honest, I think Chris has picked up on a lot of those, but just for assurance to board members, from a contracting relationship viewpoint, this is something that we fully acknowledge and we're really aware of. And we're having conversations with the clinical commissioning group around options of how we could look at revising the provision and the contract set up, so that will streamline things as well. But my main comment really was to just pick up on Di's question really. So Tim mentioned this earlier on, but a recent visit that Tim and I were on with the Children and Young People's Service and others was really it was really inspirational that actually the service managers are out there have got some really great innovative ideas of how we can meet the demand that we're currently facing and the future demand. So I think one of the big things that I'd welcome board support with is, encouraging the managers, enabling them to enact on some of those, because we were blown away by some of the great ideas that we put out there with podcasts and different means and different ways of contacting children and young people across the county. So really impressive. I think that we've got some ideas, so we will start to make a difference. Thank you, Chair.
Thank you, Mark. And that chimes with the conversations that you and I had last week when we went to Discovery House about, giving local managers a little bit of freedom to spend money on spot purchasing services and using that as a kind of springboard for innovation. And I think we had a really useful conversation about how we might, free up managers to be able to take those sorts of local decisions, and not only formally, but make sure that they understand that they can, and that we're not in a position where local managers feel that they can't spend money, or they'll be criticised for spending money, and that a measure of success is coming in significantly under budget and with things they could have spent not spent. And it's getting that balance right, isn't it, between loosening some of those controls to recognise the fact that our managers locally can do things that add value and enhance services. But we'd started that conversation, and it's one I think to bring back to this forum at some point in the future. Now, where are we? We're your section of the performance report now, I think. Mark, are we?
So
no, we're not. Jane, rather. Sorry, I'm looking at Jane. I'm thinking about you. Apologies. Jane, it's your section of the performance report.
Thank you, Chair. So this is the people section, which is the narrative, which is on page 29 of this report. We have rehearsed previously in this board meeting our most challenging risk in terms of the people agenda, which is recruitment and retention, and committed to bring a detailed report back to the next Board of Directors on our work on the supply of new people to address that risk. So just to give the board assurance that we are progressing well with that, and more detail will come forward in the next report. And in the meantime, there will be a stock take meeting which the Director of Operations, Chris Higgins, has organised about the specific risk we've been trying to address through the rapid recruitment team on our inpatient services. So that will feed in nicely to a report at the end of October to the board. I just wanted, if I may, Chair, because page 29 onwards of this report highlights quite a few workforce issues to do with the medical directorate, I just wanted to invite Dr. Ananta Dave in to comment on those specifically, if that's okay. Thank you.
Of course, Ananta.
Thanks, Jane. Happy to comment. Ananta Dave here, Medical Director. I welcome the introduction of these new metrics for the Medical Directorate, which will help us get a clearer idea of the way in which we are keeping our workforce up to date. So I just want to comment on each of them in turn. We are showing an improvement trajectory. I just want to assure board members and the public that the mandatory training program is now a regular part of the postgraduate program, with the medical education department providing support to medical staff who need to complete their mandatory training and regular reminders. So we are seeing a sharp increase in mandatory training numbers, and by the next report, I'm sure we'll be showing compliance. With regards to appraisals, people might be aware that the General Medical Council had issued a halt on appraisal and revalidation activity during the acute phases of the pandemic, which has been revised from September onwards. So the appraisals have now been picked up. We've not had to defer anyone's revalidation. So the revalidation which occurs after 5 appraisal years. So the appraisal activity is getting back on track following the easing of GMC guidance. And we have adequate number of appraisers trained, because we did a training program earlier in the year. And again, we are on track to keep up with appraisal and revalidation activity. With regards to management supervision, we have had discussions about how best to capture that, because different groups of trainees, doctors, have different training supervision arrangements. So we just need to make sure that the data being captured is for qualified non-training staff, because medical trainees might be included in current supervision and appraisal arrangements, whereas they are under the responsibility of the Deanery and Health Education England and their lead employer. So we are making sure that when we are able to provide data the next time around management supervision for medical staff, we give that narrative which clarifies the picture, and we'll be trying to simplify it as much as possible to take into account the different supervision arrangements which exist for different grades of medical staff. Happy to take any questions. Thank you.
Thank you, Ananta. Questions for Ananta or for Jane on her section of the performance report? I can see that Di's. Here we go, Andy.
Thanks, Chairman. Andy Spring, Non-Exec Director. I'm not sure this is that Jane's targets or whether it actually links back to Chris's, and it also links to the Chief Exec's report around no excuse for abuse. There are a few targets, number 43, 44 and 85, where I notice patient on patient violence, aggression, harassment and patient on staff. Roughly 1 incident per day, patient on patient, 3 on staff per day, and in the older people 1 on staff. Is there anything that we can do as a board to help support our staff in what must be a very difficult kind of situation, or is there anything more that you need from the board to help you address this particular issue? Because it's not good when we have that happen, but we also know with the client group we have, it is likely to happen.
Anita, I think you want to respond to this.
Yeah, thank you, and thank you, Andy, and you're absolutely right. It is in a good place, and as we see some of the increasing complexities that happen, so just so you know, over the last couple of weeks I've linked in very closely with our violence and aggression training team and our security. I, as a matter of course, get details of staff that have been assaulted and personally contact them and actually I have heard on the whole they feel supported by the organisation, but there have been a couple of occasions where they thought potentially we could have done more. So I've linked in with Chris, who manages the security team, and I've agreed to take the lead on a joint piece of work between the security, between the staff wellbeing service and with the violence and aggression training team, how we address, and if staff feel we're not doing enough, then that's enough for me. You know, people say to me, oh, well, we've got great process and procedures in place. Something isn't landing right if our staff are saying that. So I am just leading first meeting next week, a detailed piece of work around our staff assault processes. I'm not going to say that we will never stop that happening. You know, it isn't part of what we do. It should never be part of what we do. But unfortunately, the sheer nature sometimes of people being detained against their will when they believe they're unwell, we do find ourselves, you know, dealing with violence and aggression. It's on my radar and it's very much at the front of, but I am listening to what you're saying, Andy, and if there is things that I feel I need the support from the board to do, then we will take that forward, and I will certainly have no hesitation in bringing it back and asking for help. But I think right now we have to look at the offer and why some of the staff feel that that's not landing right for them. Thank you.
Thanks, Anita.
Thanks, Andy. It's a really good point, and thanks, Anita, for your response. And with a lot of these things, it's the perception often that's more important than the reality. So, I'm really glad to hear you say that. If it's not landing right with people, then it's not right. Thanks very much, Mark. Back to you. Do you want to draw any of this to a conclusion? I think that's been a really good conversation. We've focused on the areas that we should have focused on. Thank you for presenting the report, which has landed well, to use Anita's term. So thank you. Anything else you want to say to wrap things up?
Yeah, so just the final section for me, if I can, Kevin, just on the financial sustainability section of the report. So yeah, rightly so, we've been focusing on the key areas of our people and everything like that. From a financial viewpoint, we are hitting all of our targets, but I am very keen as a director of finance and the finance team that we work with Chris, Anita and everyone across the trust to use the money that we've got effectively. So we are, you mentioned it yourself earlier on, we are looking at more innovative ways of how we can use the non-recurrent benefits that we have from the significant levels of vacancies across the organisation more effectively to support services now and in the immediate future. So it's important that we use what we've got on that effectively. I do just want to raise to the board and public's attention our capital expenditure position. So as we'll all be feeling in our own personal lives, we're being heavily impacted on the development of our capital estate in terms of being able to access materials and supplies and labour to support us to build our new buildings. Really, our eradication of dormitory schemes are two key ones that are affected at the minute. So what we are trying to do to mitigate the impacts of that is we are trying to buy materials and equipment up front so that we've got it on site ready for when we need it, because the last thing we want is a delay in opening the units and pulling that through. But you will see in the forecast that although we are underspent year to date, we are kind of saying by the end of the year we will hit our targets. For month 6, we're actually authorised by our regulators, NHS England and Improvement, to revise that forecast. We can only revise it at month 3, 6 and 9 as we go through the year. So you will see next month's report, you will see that forecast drop down and we won't be hitting our targets by the end of the year. But like I say, we're doing everything we can to make sure that from next year onwards we can continue to deliver the effective capital schemes that we've got. I did just want to close quickly on a note about the second half of the year. So we are heading into the second half of the year this week, and we are waiting on guidance from our regulators around what our financial targets are likely to be for the second half of the year. So what we have been very clear of is that there will be a national requirement for us to make additional savings during the last half of the year as we start to claw back some of the expenditure from the COVID-19 impacts and everything like that. So what myself and the team have been looking at doing is looking at savings schemes that minimise any impact on staffing and service provision. So we are looking at sort of reporting savings around areas such as travel and those areas that we are making natural savings on as a result of the pandemic at the minute, really trying to maximise the efficiency in what we've got in terms of funding going to our frontline staffing services. So we'll work with Chris and the team to work through those cost improvements, and I will bring future updates to board on how we perform against those. But happy to take any questions on the finance section, but as you say, that's the end of our integrated performance report, and next month we will see slight revisions to the format to help support and aid conversation. So thank you very much.
Good, thank you, Mark. Thank you for that succinct summary of the financial position. I'm sure you're right that given where we are, we ought to be looking at opportunities to get the best return on the money that we've got, and not aim to underspend, as it were, for the sake of it. There is value that we can squeeze out of those pound notes, and we ought to be doing it. Yeah. Good. There are no more questions for Mark. That's been a really useful discussion, which I really appreciate. Thank you very much. Let's move on, and I think the next item, Chris, is yours on the Health and Safety Annual Report.
Yeah, thank you, Kevin. So, I won't go through the report in detail. It's there for people to read. It has been through the Sustainability Committee, so it's had a good level of scrutiny there. And really, just the main focus of that is obviously dealing with health and safety at a time where we're in the global pandemic. That's obviously dominated much of the work, making sure we've got safe places and environments to work in, risk assessments for staff. So that has been a primary focus of the work. As now restrictions are easing a bit, we're able to do a bit more of the routine stuff, and that's obviously we were monitoring closely through the Health and Safety Committee. But it's there for approval of the 21-22 work plan, and just to know, obviously we're halfway through that year and it's just a timing thing in terms of when it goes through the committees to get it signed off.
Understood. Thank you, Chris. I think a comment from Philip.
Yes, thank you, Chair. Philip Jackson, Non-Executive Director and Chair of the Sustainability Committee. Just to support what Chris said at the Sustainability Committee most recent meeting, and fully supported the report and the action plan. During the pandemic, we did fall behind with some of the inspection work within the plan, but we're catching up on that now, which is good. And generally speaking, we seem to be making good progress on health and safety issues and picking up key problem areas where we need to address them. So I would fully support Chris's comments.
Thank you, Philip. Tim.
Thank you, Kevin. Chris, yeah, I think, as I said in the Sustainability Committee, a really good report. The one comment I'll make, which I did make then, is just to reiterate that I think it'd be helpful to have the year-on-year trending on RIDDOR numbers. As with near misses and so on, you've got that, and I just think it would sort of help. There is a technical question around, can we start applying statistical process control analysis on that to see whether we've got a true trend or whether it's just sort of natural variation, but that's a development down the road. Thanks.
Thanks, Tim. I see no other questions or comments. I've nothing to add to what colleagues have said. This is had a good going over in Sustainability Committee, so I think the board can happily receive the report and work plan. Thank you, Chris. Grateful. Peter, I think the floor is now yours with at the review of governance and board committee terms of reference.
Yeah, thank you, Chair. I'm Peter Howey, I'm the Trust Secretary. This is the annual review of the governance structure and the terms of reference for the board. I have included in the appendix the very large chart that shows all the committees in the organisation, and then just a few key points. So if I can just make a couple of key points and then perhaps go through just literally one set of terms at a time, saying agree or not. So the committees of the board are the ones that were set up after the review of the governance structure last year, and there's an overall view that those remain fit for purpose and appropriate at this time. Each of the committees, with the exception of the Appointment Terms of Service Committee, has done their own review of their terms of reference, and that is what is proposed today for board approval. So the committees have recommended those to the board for approval. There is, in terms of the Appointment Terms of Service Committee, slightly different things here. What we've done is updated those in line with the Standing Financial Instructions and Scheme of Delegation amendments that the board approved in July. The one point that was raised in, I think, two of the committees was that the reporting clause that allows for the chair of the committee to draw to the attention of the board things that require a disclosure across the whole board. There's a proposal to extend that to enable chairs of the committees to talk to each other about moving things between the committees. So that proposal is in. I just point out that I think there remains a safety net there that as and when that happens, that actual action then needs reporting to the board so that everybody is aware that that's happened and we have it on record. But I don't see there's an issue in including it. We have included it in the draft of the People Committee where it was discussed. It's in the draft of the Sustainability Committee where I think it was agreed for some wording to be discussed after the meeting, but it's not been put into the Quality Committee. So I think if we were going to put it in one, we would want to put it across the whole set. So that's a decision for the board to consider. And other than that, I've just proposed that I will go through each of the terms of reference, and please note there will be an additional paper coming back one of the remaining board meetings this year to suggest where staff networks should appear within the structure, because although they exist, they do not appear within the governance structure chart, and their reporting arrangements and the necessary support for that will come back as a separate paper in one of the remaining board meetings this year. So if there's any general questions at this point, we'll take those, and then otherwise I'll go through each at a time. Kevin?
Yep, Sarah has a comment.
Thank you. Just one point, Peter. In the organisational chart, I'm down as the chair of the LNC. I don't know whether that's. If I am, I've never been asked to do it. So.
It is an error, Sarah, and I have asked for somebody to confirm for me who actually chairs it. I'm afraid I can't answer now, but we will get it corrected.
Thank you. Thank you.
Okay.
Thanks, Sarah. So do you want to take each of the proposed terms of reference in turn and ask the question of the board whether or not they agree, Peter?
Yeah, I'll do it very quickly if that speeds this up, Kevin. So Audit Committee has proposed no changes. Still fit for purpose, no changes. So I don't know if you want to do it by exception, Kevin.
If anybody doesn't agree with what's being proposed, then put your hand up or comment in chat.
Okay. Okay. Quality Committee. The Quality Committee note the inclusion of the infection control bit really, and that is the only major change. If we do agree to include the between committee reporting, we would add that in as well, but we can take that at the end and we can add it if we need.
Okay. No one has any comments on that.
Okay. I spotted in the chat bar that Jane is saying that she would like to make a comment on the People Committee. The People Committee one, you'll see there are some changes to the membership of the People Committee, and this is the only committee where people below directors would be members, and it's the 2 associate directors of People, which this proposal puts them into the membership and therefore makes them part of the quorum, and we've amended the quorum slightly to allow for that. This one does include the reporting between committees, and very helpfully Di helped us with making the syntax fit better through the rest of the document as well, which is why it shows a number of changes there. So I'll let Jane speak. So
Jane, your comment.
Thank you, Peter. Jane Marshall, Director of Strategy and People. The comment I wanted to make, Chair, is that addition of associate directors to the People Committee is the only example, I think, so far of where we've got that difference, but the accountability would still rest with the executive director in terms of, that's just the governance of that, and I wonder if it's worth making that point, but I'm happy to take Peter's views on that.
I'm more than happy, Jane, to keep to actually under the membership we can just add them in as fixed attendees rather than members, and that would make that clear.
Thank you, Peter. Thank you.
If the board's happy with that, that's fine by me.
That sounds entirely sensible, Peter. Let's do that.
Yeah. Okay. Yep. Okay. And then Jane, it does mean just under the core bit, I'll make a slight change to the wording there as well, if everybody agrees, so that one of them can act as a deputy for you, but not independently. If that makes sense. Is that? Yeah. Happy with that? Yeah. Okay. So I'll make those amendments, and if subject to those, if we can approve that one, that's great. The Sustainability Committee. There are a number of amendments in the Sustainability Committee, these relate to the movement of the budget setting procedure that used to sit within Audit Committee across into Sustainability Committee, although it wasn't actually in the terms of reference to the Audit Committee, also brings in a much stronger link to the ICS and the developing system, and is very clear around the net zero objective that Sarah took the paper earlier in the meeting today, and this one does have in it that proposal for the share between chairs as well.
Thank you, Peter.
Any comments on that one? Are we happy with that one?
No comments on that one.
Okay, so the next one is the Appointment Terms of Service Committee. We we simply didn't have an opportunity in the sequence for the committee to look at it before today. But what I have done is propose the amendments in here in line with the scheme of delegation amendments that were made and approved by the board in July. Otherwise, there's no recommended changes to that one.
Okay, thanks, Peter. No comments on that either.
Okay, can we just agree then on whether you would like this sharing between chairs approved and added? It won't go into the audit committee one because they would report differently, but it would go into the quality committee.
Yes, please. It sounds sensible. I can't see any reason why we shouldn't.
Okay. Okay, so.
Yep. I think people are content with that.
Yeah. Okay, so
great stuff. Thank you, Peter.
Move on. Yeah. Okay.
Let's move on.
Yeah, move straight on to the forward agenda then. The forward agenda, there are significant changes to this time. We bring this every 6 months and it has a few tweaks. This time it's significantly changed. And the significant changes in here reflect the outcome from the board development session that we held in August. Fundamentally what it does is it moves the strategic part of the board to the front end. So the chief exec's report will frame the rest of the discussion for the meeting. In a little bit like the reference we've made where board assurance frameworks is framing the committee discussion, the chief exec's report would frame what was coming in the meeting. So we've got the strategies at the front. We have directly linked all of the reporting to the committees who scrutinise those reports and provide them and group them together under those similar headings to before, but with the committees. The regulatory section at the end, some of that does come through audit committee, or the majority comes through audit committee. There are 1 or 2 bits that don't. We've put all the annual reports from committees in the regulatory bit at the end, purely because they relate to the Foundation Code of Governance, and it's a regulatory requirement to have them, but we could separate them out under each committee heading if you would prefer. Otherwise, very similar reports to those that have come before, but ordered in a way that fits with our assurance processes, the board assurance framework, and allows the board meetings to be set in a context on each occasion we meet. This does need approval, Karen, if people are happy with it. Or any comment?
Thank you, Peter. My personal view is that the proposal's constructive, reflects the conversation we had in board development and ought to be what we do. So if anybody disagrees, please let me know. There's lots of agrees in the chat, so can take it that the board has approved that. Thank you, Peter.
Okay, the next one then is the forthcoming board programme. It is as it's written, but I would just like to make a couple of points, if I may, and that is that we are looking in October to find an hour which would be a masterclass on the safe staffing model. And the board will recall at the last meeting there was some questions of detail, and we agreed that we would put on a session. And I will look for the best and most available hour we can find, probably linked before or after some other committee during October, and offer that as a development opportunity for people to come and see. So I'll work with Anita and her team and we'll put that together. And the other thing, just to flag and remind everybody, is we're talking about in January having an extra board development session, and that board development session we're thinking about putting in the afternoon that is the audit committee afternoon, in the afternoon after the audit committee. I think it's 13th of January, I think is the date, but I'll confirm that after the meeting. You heard Sarah talking about the net carbon zero and sustainability green plan. It may be that we could conveniently tie that into that and agree that whilst we're all meeting that day because of the time frame required. But the primary intention in January of that extra board development session would be to look at the ICS ways of working and the trust future ambition, as you mentioned earlier, Kevin. So that's the plan for that forward program.
Thank you, Peter. Any questions or comments?
I can see some typing going on.
I can see some typing going on. And Tim has appeared. Have you got a question or a comment, Tim? You're muted, I'm afraid.
Thank you. So the assumption is that we continue with virtual meetings until at least the end of the year, and then is it going to be reviewed after that?
That's our current assumption is now the rest of this year, with a view to hopefully releasing some of this to start to be back in person from the beginning of next year.
Thank you.
Sarah, you have a comment?
Yeah, just tying it back to the Chief Executive's report, we do have that risk assessment framework now, which is live from this week. So it's something that we could maybe pick up initially at the executive team about what that risk assessment review might look like for elements of board governance. So we can pick that up as an action in terms of
I think it's worth doing that. So rather than just assuming that everything's going to roll forward, that might well be the outcome that we carry on, rolling forward. But it would be, I think, as well to do some active risk assessment around that before we reach the conclusion.
Yeah, thank you.
Thanks. Don't think there's anything else for you on that, Peter. Thank you.
No, that's it. Thank you.
And we've saved the best till last. Mark, I think it's you now on Treasury Management Policy.
Excellent. Thank you, Chair. So good morning. So yeah, Mark Platts, Acting Director of Finance and Information. So just presenting to the board the updated Treasury Management Policy. So this is a policy that we're now proposing to refresh every 3 years, and this is the refresh year. So essentially, to be honest, because of the nature of the markets where we're at, there's very little changes in there. We are quite restricted on where we can and can't invest. So the policy just ensures that when we do invest, we do so safely and securely. So not a lot of changes on there, but presents it for approval if that's okay, Chair, and look forward to bringing it back in 2024. Thank you very much.
Thanks, Mark. I shall look forward to you bringing it back in 2024 as well. Any questions or comments for Mark? No, I don't think so. We don't have any other business, so I think that concludes the public element of the Board of Directors meeting for today. So thank you very much, everybody, for taking part.